Hi, today we'll go talk about primary immunodeficiency, which include DiGeorge syndrome, severe combined immunodeficiency, X-linked gammaglobulinemia, common variable immunodeficiency, immunoglobulin A deficiency, hyperimmunoglobulin M syndrome, Wiskott-Aldrich syndrome, and complement deficiencies. DiGeorge syndrome is development failure of third and fourth pharyngeal pouches due to 22q11 microdeletion, present with T-cell deficiency, lack of thymus, hypocalcemia, lack of parathyroid, and abnormalities of heart, vessel, and fades. Severe combined immunodeficiency, defective cell-mediated and humoral immunity. Etiology include cytokine receptor defects, cytokine signaling is necessary for proliferation and maturation of B and T cell. Adenosine deaminase deficiency. Adenosine deaminase is necessary to deaminate adenosine and deoxyadenosine for excretion as waste product. Buildup of adenosine and deoxyadenosine is toxic to lymphocytes. Major histocompatibility complex class II deficiency MHC class II is necessary for CD4 positive helper T cell activation and cytokine production, characterized by susceptibility to fungal, viral, bacterial, and protozoal infection, including opportunistic infection and live vaccines. Treatment is sterile isolation, bubble baby, and stem cell transplantation. X-linked gammaglobulinemia is complete lack of immunoglobulin due to disorder B-cell maturation. Pre and pro-B cell cannot mature due to a mutation of Bruton tyrosine kinase. Disease is X-linked recessive. Present after 6 months of life with recurrent bacterial enterovirus, polio and Coxsackie viruses, and Giardia lamblia infection. Maternal antibodies present during the first 6 months of life are protective. Live vaccine of polio must be avoided. Common variable immunodeficiency, low immunoglobulin due to B cell and helper T cell defects. Mm, Here we see granuloma, and image A is non-caseated granuloma, which include lymphocytes and macrophages around normal tissue, and caseatin, which is necrosis in the center, and angioedema in patient with immunoglobulin A deficiency. It occurs when plasma with the immunoglobulin A transfused to a patient with immunoglobulin A deficiency. Also, common variable immunodeficiency. In this patient, we see increased risk of bacterial, enterovirus, and Giardia lamblia infection, usually in late childhood. Increased risk for autoimmune disease and lymphoma. Immunoglobulin A deficiency is low serum and mucosal immunoglobulin A, most common immunoglobulin deficiency. Increased risk for mucosal infection, especially viral. However, most patients are asymptomatic. Hyperimmunoglobulin M syndrome, characterized by elevated immunoglobulin M due to mutated CD40 ligand on helper T cell or CD40 receptor on B cell. Second signal cannot be delivered to helper T cell during B cell activation. Consequently, cytokines necessary for immunoglobulin class switching are not produced. Low immunoglobulin A and immunoglobulin E result in recurrent pathogenic infection due to poor opsonization, especially at mucosal sites. Wiskott-Aldrich syndrome, characterized by thrombocytopenia, eczema, and recurrent infection, defective humoral and cellular immunity. Bleeding is a major cause of death due to mutation in the VASP gene X-linked recessive disorder. Complement deficiency is C5, C9 deficiency increased risk for Neisseria infection, Neisseria gonorrhea, and Neisseria meningitis. C1 inhibitor deficiency result in hereditary angioedema, with characterized by edema of the skin, especially peripheral and mucosal surface. Today is end. The next topic is autoimmune disorders. Thank you.